Hello and welcome to Rural Doctors. I'm Simon Stokes. This program focuses on adolescent mental health. The teenage years can be difficult for anybody, but they're also often a time where mental health issues first emerge, and engagement in health services at that critical time can have a huge impact on people's well-being. Later in the program, we'll hear from the Drug and Alcohol Youth Service and Youth Focus to discuss the support they offer teens struggling with substance abuse and mental health problems, and to hear their approach to engaging young people in appropriate services. But first up, Dr. Olga Ward talks to Dr. Christopher Lee and Dr. Margaret Lumley about personality disorders in patients of all ages, but with a focus on that point, so often in adolescence, when problematic behaviours start to differentiate themselves from normal teenage problems and anxieties.
Well, Margaret and Chris, welcome to the program.
Thank you.
In general practice, we quite often see patients who are at enormous crisis points in their life, and sometimes their reactions are quite predictable, and sometimes things just don't quite look or feel normal. What are the clues that tell you that a patient's got a personality disorder or some quite odd sort of traits, and how do you tell the difference between a kind of a collection of annoying behaviours and somebody with a personality disorder?
Severity kind of like makes a difference, because definitely people can come in and distressed and have a lot of painful emotions, and their life's quite dysregulated without necessarily meeting the criteria of personality disorder. We just save that for the more severe, when it's kind of totally disrupting their thoughts and their feelings and their behaviours and their interpersonal relationships.
The way I think about personality disorders, personality of course is what gives us our colour.
Yep.
And there are aspects of personality which are desirable and wonderful. You know, we talk about someone who's got a big personality, and that's usually an endearing way. Personality disorders are people who have always been like this, and who have a very rigid, narrow repertoire of behaviours that they do to extreme. So we all do stupid stuff on a regular basis.
Yep.
We all have intense feelings that we don't like, or you know, make horrible mistakes in our lives from time to time. But people with personality disorders do these kind of regularly, so they don't have the range of options that a normal personality has. They are limited to a very strict sort of minute, repertoire of really unhelpful ways of looking at themselves or looking at the environment and dealing with themselves and the environment.
Yeah.
So that they develop a sort of caseness. It becomes obvious that they've got a sort of disorder. And these are the ones that, you know, get referred along for help.
Yeah. Now, you said it had, you know, that they'd behaved like this forever.
Yeah.
Can you identify it in kids or teens?
You can see early stages of personality disorders in young people. Probably not in pre-teens so much as, although some children are always very anxious, but that may be about something else. But in teenagers in particular, you can start to see them developing traits. For example, one of the common personality disorders is antisocial personality disorder, and conduct disorders, and a range of other really fairly antisocial behaviours will be seen in young people, and then that can develop later on. It doesn't always develop, but it can develop later on into adult antisocial personality disorder.
So these are the kids that you kind of identify who graduate from pulling the wings off flies to torturing their puppy and sort of strangling their little brother.
That's the ones,
The problem is that people with personality disorders, with a lot of them anyway, they have a lot of problems controlling and regulating their emotions. They tend to be all over the place with those, but we also know that adolescence is a time where our emotions are all over the place, so it can be a little bit difficult knowing whether this is just a stage thing that someone's going through, or whether it's start of a more enduring pattern.
So now, how do these things develop? And is there a chance that if you jumped in early, you could head off some of the rigidity that Margaret was talking about in terms of response?
We're not really sure entirely how it's developed. There are certain things that do seem to be important. There does seem to be more trauma experiences in people with personality disorders than those without. Some environmental things also seem to impact upon their experiences. We know that there's probably some biological influences. So
when you say environmental, are you talking about like a violent social environment, or are you talking about exposure to cigarette smoke, or
right.
whatever?
From my understanding of it, it will be things like the type of interactions that a person sometimes has with their caregivers can be important.
I mean, obviously some things are inherited, like your sort of character, whether you're a phlegmatic sort of person, laid-back person, or whether you're very antsy, it's inherited. And that is a sort of broad framework for people with their personalities. But a lot of people develop ways of dealing with the environment that they sort of have to, because there's no other way of dealing with the environment. And children need a certain amount of, they need compassion from their parents, they need support and care from their parents, they need to have healthy experiences of fighting with their parents, really. They need to, we need to have conflict in order to grow properly. And in many families, the parents aren't able, or either transiently or permanently, are not able to provide these sorts of experiences that children need. And so the children have to develop something other than the normal way of dealing with things. So example, for a parent who is incredibly messy in their life, the child will often develop a very OCD response to this, in which the parent is, the parent may be alcoholic or otherwise drug addicted, or borderline personality disorder themselves, and just not able to provide stability and security for the child. And the child would very often develop a very careful, restricted, rigid way of dealing with things, so that everything has to be just so. And they can carry that on into adolescence and adulthood as a sort of anarchistic or OCD sort of personality style, for example.
Something that they can control in their environment.
Yeah.
What about those families where you see, 3 kids in the family and 2 of them are cruising along normally with what seems to be really good parenting, and then you've got the one that's the bad egg?
Yeah, well, it's said that every child has a different mother, and so it's hard to know if that's a combination of genetics and environment, or what is actually going on in those families. And I'm tempted here to start talking about people I'm actually seeing. For example, one young patient who's the one girl in a family with 2 other brothers, and her mother has obviously got some major issues with girls, and there's some reason to understand what this actually is and how this is actually acting. But this child is developing a raging personality disorder, whereas in fact the brothers are fine, because she's being treated completely differently in extreme ways to the way her brothers are being treated.
That's interesting.
Simply because she's a girl, is how it seems.
The other thing that we've been talking about is an effective environment and like a biological predisposition, but I think also there can be an interaction happening, so that sometimes what might happen is you might have a particular biological predisposition. You then have experiences from the environment that perhaps represent trauma or are harsh in some way, and really good evidence now that can change brain chemistry, and then that can make the person more hyper-aroused, more sensitive to other kind of emotional things. So you get an exacerbation of each of the factors. And there's an interesting study looking at hippocampal volume in women with major depression and women with borderline personality disorder. And what we find is that if you can match women for age and IQ in both groups, you do find that women with borderline personality disorder have smaller hippocampuses, which is kind of like consistent with other studies that people have been through traumatic experiences.
And just remind me what the hippocampus does.
The hippocampus kind of like puts the context onto things, which I think is really important. Following what Margaret said earlier, is that people with personality disorders in general tend to react in exactly the same way, use exactly the same coping strategies, even when the context actually changes. So if the hippocampus is supposed to help us work out that this is slightly different from that, and therefore we might need a different response, if it's shrunk and not as active, it impairs our ability to do that. So whereas rage might be appropriate in one situation when our needs are frustrated, it may not be appropriate in the workplace, kind of for instance, and someone with a personality disorder will have an impaired ability to make those context distinctions.
Seeing these disorders develop, Are there any early interventions that you could put in place if you saw a child or a teenager that you thought, you know, they're at risk? And, you know, as a general practitioner, I guess we do see these teens and, you know, early teens and late teens, and we think, oh gosh, the whole family's getting into trouble here, you know, with the family reactions and the child's behaviour. Are there any programs that kind of really help to produce some adaptive behaviours or some perspective?
From my point of view, when it's in the teenage years, since a lot of the personality disorders are about problems with managing mood and behaviours, other things that can improve a person's ability to manage their moods or behaviour can work. So there are, in the schools for instance, people are taught some mindfulness skills as part of the general education program. That would be a good thing. Yeah. There's also in some schools they do some types of cognitive therapy, a learned optimism type program. That would be a good thing. Improving supports within the school would also, I think, be a good thing. Reducing bullying, having a policy on that, those things I think would all be useful.
Schools can be quite helpful in kind of non-specific ways, because sometimes people who are able to engage with an adult in a helpful way can make up for not being able to engage with their parents in helpful ways. And so teachers are in wonderful positions to be able to support and nurture a child that has kind of not received that from home. But that's fairly ad hoc. That's not something that's built into the school curriculum.
And it's
program.
A big load for the teacher as well.
And it may just be in the context of being in the classroom and, you know, noticing that child, or perhaps, you know, encouraging them and things like that. It might not be too onerous. It's not about taking on a parental role. It's about being a bit of a role model sometimes and being kind to the child and so forth. But that's not regulated. That's quite ad hoc. So some children can really use the interest of a helpful teacher, but it's not something that's prescribed or, you know, made regular.
Yeah. Margaret, there's something that always kind of bothers me about personality disorders, and that's the label. You know, you say, oh, somebody's borderline, and I have a vague idea what borderline personality traits at least are. What's at the borderline between, and is it helpful to stick a label on that says borderline? Does it just make health professionals go, yeah?
Well, borderlines are the borderline patients are some of the most obvious patients that have problems, because they're so intensely interpersonal seeking in terms of their desire for attention and time and effort and so forth. So they're the ones that come to our awareness so frequently, but there's lots of other personality disorders and people suffering silently who often don't get noticed. Borderline is an old term, and it's referring to the border between neurosis and psychosis. So neurosis is anxiety disorders and mild depressions and OCD and things like that, and borderline patients are seen as sitting in the intermediate zone between that and psychosis, where people lose control of reality and, you know, start to hallucinate and believe things that aren't true. And borderlines typically do have brief psychotic episodes. When things are very stressful, they can have those brief psychotic episodes. So it's an old term meaning that. Yeah. The interesting thing about that is a lot of people like being told that they've got borderline personality disorder. They go, thank goodness, finally there's a label that explains why I've had such a horrible time in life. And they're pleased to be able to say that. One of my patients goes, oh, I'm being so borderline, whenever she's really feeling terrible. And she actually delights in that.
She's playful with it.
Yeah, she's a very playful lady. One of the things about borderline personality disorder, which is often missed, is that they're very intensely emotional. And the intense emotions also run to delight and joy and playfulness. So borderlines are actually really engaging and delightful in many ways until they start cutting and burning and you know, running amok. There is a delightful character to borderlines because they're so intensely joyous on some occasions.
And they swing.
Yeah, they do swing, definitely, without provocation and without warning. But they don't mind being called borderline, bizarrely, even though you've got disorder after it, meaning there's something wrong with you. They like the
I would agree with Margaret in terms of making the diagnosis seems to be helpful.
Now, if someone narcissistic, that's a different matter.
That's a bit harder. But the
or sociopathic, although they probably don't give a toss to
that. They don't care.
One, I think there's an important warning though. I think in giving the, if the GP is going to think about giving the diagnosis, one thing to do is to warn the person about being sensitive to go off and looking at the internet for things that you find about borderline personality disorder, because there's still a lot of bad press and some poorly educated people giving an opinion about that. So they'll read things that just simply aren't true. So they'll read things like it can never be cured. Well, we know it can. And they'll read things like they only get into difficulties because they're manipulative, etc., etc., etc. So if you warn someone that there is some bad press out there, and don't believe everything that you read on the internet, which of course people know, but a nice reminder.
They know
of that.
until they read it.
Yeah.
And the other thing is people diagnosing themselves off the internet. People go, I was reading the web and I've got borderline personality disorder. And I'm like, no, you don't. Anyone who reads the criteria for borderline personality disorder thinks, I've got it. Because borderline personality disorder is just a bunch of traits that we all have. The trouble with borderline
I think this happens to every medical student, isn't it?
Exactly.
They've got every psychiatric diagnosis, as you learn about.
And, I died of lupus for a long time while I was a medical student, but so things that are a little bit nebulous, people easily read themselves into that, and it's trying to get across that, no, you actually have a normal personality disorder, you're not borderline, you're struggling a bit at the moment is sometimes quite helpful too, and that's where GPs can be a little bit more sensible, because they'll know whether or not people have personality disorders or any other disorder when they've been reading the net and think, oh, I've got this.
Yep. Do you find it helpful to kind of, in your mind, sort of cluster them into groups or groups of traits so that you can make a therapeutic
I think
advance with them?
Coming from a medical background, I think you can't avoid it. There's the weird ones, there's the wild ones, and there's the wimps. So there's clusters A, B and C. And this is partly because personality disorders don't neatly differentiate themselves from each other. So people with one personality disorder can very frequently have traits of other personality disorders or syndromes of other personality disorders. And there's various reasons why this occurs. But in DSM at least, ICD has got a different approach, but DSM clusters them in terms of the weird ones like schizotypal personality disorder, which is sometimes seen as a form of schizophrenia anyway, paranoid personality disorder and the like, and the wild ones are the ones, the cluster B ones are the ones that present to us all the time, and they're the borderlines, the histrionic, the narcissistic and the antisocial, and there's also the WIMPs, the dependent personality disorders, and the more anxious personality disorders. So these different clusterings are important with regard to treatment and the response of organisations to them, really.
Yeah, I'm sort of thinking about some patients who have, passive-aggressive traits and very dependent traits and quite avoidant traits and are anxious and have this sort of background paranoia. I'm just sort of picking two patients who've kind of come to the top of my mind. Given that those are coming from some from the weird and some from the wild and some from the wimpy, how would you kind of go about starting to
different therapeutic approaches can work for different people.
I don't know if we have great therapeutic approaches for the first cluster, the cluster A, so the schizotypal, schizoid and paranoid personality disorders. We don't seem to have something that can really tell us this is going to make a difference so much for their lives. I think you approach the therapeutic relationship a little bit differently, but unfortunately I'd like to be able to say I can do something to help these people. I'm not sure I can so much.
Antipsychotics don't help at all?
They can to some extent with the
paranoid types?
The schizotypal. But there's different forms of psychotherapy. I'm psychotherapy mad, of course, and if you can engage people, then you can help them to do things differently. That's the important thing about psychotherapy.
I think I would match a little bit more from the diagnosis, kind of like a bit more about what particular needs they're more likely to have given that diagnosis, and adjust what I might need to provide in the therapy. I think that does happen with the other groups.
Some of my patients have had some really terrible childhoods, and my sort of brief time as a psych resident exposed me to patients who'd had really, really terrible childhoods. You wonder how they've survived and kind of managed to get on. Where do you start?
Well, I think the thing that's really wonderful is that people do survive horrendous childhoods, and they're quite often really lovely people. they may be troubled or not. Some people manage to almost escape unscathed, and this is a great mystery. And they talk about, resilience and where does this come from, and how would you therapeutically try to increase resilience, obviously. But I think no matter what sort of childhood you've had, the important thing about therapy is how do you make use of what you have in the present. And that's what most of the therapies are geared towards at the moment. Okay,
so
these things have happened to you,
yeah.
and you might need to do more intensive therapy and go back there and grieve for the things that you missed out on as a child. But there are also really positive ways that you can enlarge on your existing strengths, because having a terrible childhood sometimes does leave people with quite impressive strengths. And all therapy is about enlarging on people's existing capacities and learning new strategies to deal with things that they're not so good at. So it doesn't become a problem in that sense, because you're dealing in the present in a very positive way with people, and people respond to that. Yeah.
I might add a little bit, sort of pet interest at the moment is that kind of like the two main therapy approaches that I might take would actually start probably with an insight focus, so that within the first, someone with a personality disorder, within the first week, that they have an understanding of how it is they got to this point, given what's happened in the past, and that they can make some sense of the things that they do that are problematic, the behaviours that get them into trouble. If they could see a relationship between what's happened for them in the past and how they cope with it in the past, and that's why they're acting now, I actually think that that's a major piece of the work, and that from that shared understanding that you develop with the patient about that, good things happen from there.
Because that's about giving them an understanding that they can build on, and it's also giving them a huge thing, which is your understanding of where they're at this time in life.
Yeah.
Yeah. So, given that I'm assuming that this type of therapy takes a really long time.
It depends on the personality disorder and on the severity of it. So if you take, in the American Journal of Psychiatry this year, there's a study that looked at basically a year for people with that cluster C personality disorder, with the avoidant and dependent, and got some reasonably good cure rates, people no longer meeting criteria at a 3-year follow-up. So there's that. Borderline personality disorder and the severe thing might take a couple of years before you start seeing people symptom-free in terms of, well, not meeting the diagnosis anymore. But then there are, Margaret and I were talking about this before, but there are higher level functioning borderline patients who might come to a GP who probably perhaps already have a job and they have a supportive person. That would be different to what you would have seen as a resident in a psychiatric kind of like service where things are totally chaotic, nobody's working, they're in some forensic issue at the moment. For those people you need a couple of years. For the others, maybe something good can happen in a year or even 6 months.
So this is actually very encouraging for country doctors. I'm sure you're aware of how fast personnel turn over in country mental health services, and often the patients will establish a therapeutic relationship with someone and then they're no longer there. But the GP is the long-standing person. If you were going to give a GP some advice about very brief things that they could do that would be supportive for those patients, what would you say?
Well, simply just checking in with them on a regular basis and encouraging them can be really, really important, with an expectation that they do useful things and try to manage themselves differently. There's a huge impact from just the expectations of someone that the patient looks up to. And that can be, the GPs can really capitalise on that. Most GPs are fantastic at doing therapy. That's what you do.
Yes.
That's your job.
In the 4.5 minutes in the consultation that you've got.
Very effective, very cost-effective therapy. So just being there and encouraging and offering support can be incredibly important, because quite often these people do feel very isolated and alone and frightened, basically. So to break through that a little bit would be really helpful, because I know there's not very many resources in rural Australia.
No, particularly not in terms of long-term or even short-term psychotherapy.
No. No.
Chris, anything
So,
to add?
yeah, I would just second that. I mean, by definition, someone with a personality disorder has to have problems with interpersonal relationships. So the relationship that a GP has with the patient is an opportunity to provide some connection that might be absent in other parts of their life.
And we'll return to that discussion in a moment. Chris Harris is the Clinical Services Manager at the suicide prevention organisation Youth Focus. He spoke to us about how important it is to make that connection with adolescents who are self-harming or have suicidal ideation, and how to encourage them to engage support.
Youth Focus was set up 21 years ago. At that time was in response to the death of a young person through suicide. And at that particular time of feeling that there wasn't services available for young people. And so it was originally set up very much as a drop-in centre, a youth work-oriented model. And over the 20 years, the nature of the service has certainly changed, and over the past 2.5 years. The youth focus model now is what we call a Tier 2 mental health service. So we see young people aged 12 to 25 who present with moderate and to severe levels of depression, anxiety, and we have an emphasis around those young people who have deliberate self-harm and who have thoughts associated with suicide. Youth Focus is a not-for-profit organisation and quite a unique not-for-profit organisation within the mental health youth sector. In so much that approximately 80% of our funding comes through fundraising, philanthropy, donations, and more recently research funding through Lotteries West, some research grants with the Telethon Kids Institute. What that means is for the 20% of funding coming through government and Department of Education, the Mental Health Commission, it allows us to position ourselves differently to government mental health services, which means we're looking at early intervention, which means a young person doesn't require a diagnosis to come into the service. What we're looking at is identifying some of those behavioural changes that we might see in young people at an earlier point that may be predictive of developing a more clinical picture later on. So what this means is that in terms of referral, and our most common form of referral is through schools. We currently have clinicians working out of 48 schools, as I said, through regional and metropolitan areas. So about 30% of our referrals come through schools, support services, and then we have about 30% who come through families or self-referrals, and we have around 15% who are coming through GPs. So what that says in that 75% is the referrals are coming at a much earlier point than what you would see through a CAMS system, etc. The service we provide is free, and part of that free service and not necessary to have a diagnosis was so that we could actually, the young person, we didn't get distracted by a label or the diagnosis per se. While we understand that that's an important number of areas, the ability to intervene earlier we know will improve outcome and prognosis down the track. 90% of young people referred to Youth Focus have depressive type symptoms. About 40% also have comorbid anxiety-based symptoms. What's really important to understand is that mental health-based conditions exist on a continuum, stemming from normal functioning up to where we then give a diagnosis. So when we have a look at a young person who may experience some sadness and that's not addressed, or they get a message which is around, no, you don't feel sad, or you know, no, don't get upset. Over a course of time, and given the right vulnerabilities and circumstances, that sadness can start to become heavier, can weigh them down. they'll start to link that with kind of feelings of kind of hopelessness or kind of what's the point. They lose interest in some of the things that they might ordinarily be interested in. We group those phenomena together and we call that depression. That's how mental health and our diagnosis works. The advantage of understanding that, and for GPs, is that along that continuum is we're looking for particular points of which we can notice some of those changes early. And what we don't want to look for is wait till it becomes at a diagnostic level, or what we call at a clinical level. But those signs are there, and they're predominantly within behavioural changes. So we're always looking or asking for the young person or their family, have there been some changes in behaviour recently? And those particular changes are often around in terms of performance, attention, concentration, changes within peer relationships, changes within school performance, whether there's an increased response to particular situations, i.e. going out that are over and above what you might have expected within your young person. So once we notice those, or parents say that there's a change, is what we don't want to do is dismiss those and say this is a fad. One of the greatest challenges is going to be, is this around normal adolescent development, or is this moving into what we might later see as a mental health related condition? So the role then of a GP, rather than merely acknowledging it as adolescence, we hold that in mind, and then we watch and notice, and we encourage parents to watch and notice these changes over a period of time. Is it just a result of a situation, exam period, and then it passes? But if those changes kind of in performance, mood, social interactions begin to persist, and certainly 2 weeks, 4 weeks or longer, then what we need to do is to actually have a look or intervene around how we can support these young people. And some of that may be through GPs of regular contact, but certainly we always say that for general practitioners is being clear of that role and then knowing when to refer on. And Youth Focus would certainly would say that we are the next line within that referral process. So I think it's around educating, intervening early, GPs feeling confident in how to frame this and finding ways to frame it. And that's the same when I spoke before around, so when we have a look at something like self-harm, which from the outside we stop and think, how or why could somebody do this? What we do understand at the moment is, in terms of self-harm, there seems to be an impaired emotional regulatory mechanism within our neural pathways. So that the ability to kind of regulate emotions, determine do I need to focus on the detailed bigger picture, or cognitive flexibility is kind of not there. But what that means is people have these overwhelming emotions that they can't regulate. And in terms of the cutting behaviour, what we've now come to understand is rather than the behaviour itself, which can be distressing to see, it has a neurochemical impact. And that, what we understand that to be is, in the self-harm behaviour, even if somebody says that they're numb and can't feel, it has a direct impact neurochemically. And we know that that will have the effect of reducing cortisol. It will give the impression to the young person that there's this short-term regulation of emotion because the pain response overrides the emotional distress, reduces cortisol. I'll often use an example with parents, or say if they're worried about something at work but they slip and cut themselves, and for that split second that distress and worry about work goes, and that neurochemical response takes over. It's not functional in the long term. It doesn't actually remove the problem. It doesn't lay down new pathways in terms of emotional regulation, but it's not young people being silly. It's not attention seeking. In actual fact, it's young people saying, I'm in need of some attention because I'm not sure how to manage my feelings. And I think, again, if we can understand it in a more normal context, and GPs are able to then let parents know around this, then it can begin to make sense. And that's certainly not, you know, I still struggle to see young people harming themselves and what they're able to do to their body. But I'm able to understand, okay, there's a pathway, there's a function around that, and we need to put other things in place, so that's not the preferred method. What we're talking about here is an actual fact around motivational interviewing and motivational enhancement therapies, to give it a name, and for GPs, which is you're always looking at that point of leverage for change, that motivational point. And sometimes that isn't specific to the particular behaviour. So for instance, GPs, a young person comes in with an eating disorder, will have reduced motivation around making changes to their weight or eating around that. But if with a young person, because they might come along, I don't know why I'm meant to be here, and I might kind of go, is it causing any problems at home? Yeah, I'm fighting with my mum all the time about what to eat. Would you like that to be different? Would you like to fight less with your mum? Yeah, I'd kind of like that to be the case. And they might say, but I'm not eating. I said, no, I'll leave that for now. You'd like the relationship to kind of be different, or that be finding. So you're open to explore kind of some things we might be able to do differently around that. They might go, yeah, I'll go with that. And they might kind of go, just by the way, I just need to check your blood pressure while we do that with and we can get your mum in a minute. And now the leverage for change might be around the relationship, but we know that, and some studies which say if we get some leverage for change around a particular area that the young person's invested in, it increases our likelihood of leverage for change in other areas. The impact of first contact, and certainly around mental health services or addressing mental health related issues, can have a significant influence on the path or trajectory of that young person. If it's a dismissive approach initially, then that can set the person back in terms of function, and in terms of years lived and their achievement, can set them back many, many years, because we hear that young people will often not return or go and seek help again. And when we think of such things as burden of disease, not only financial cost but impact on function and for young people and then into later adolescence, our investment has to be in terms of early identification. And with early identification, we have to move away from previously held myths, stereotypes, stigmas, even within our own profession. Intervening early also involves recognising the role of the family, and we have to move away from a family is to blame model. In fact, now in mental health and for young people, families are our greatest resource. Even where families where they may have reduced capacity, a dad in prison, a mum using alcohol, but we still recognise within that capacity that they're their parents. They may not be able to lead to the point of change, but we let them know. Because ultimately as a service, and for GPs, is we're always going to be wanting to move the responsibility either back to family or community or schools, etc., not within that 10-minute session with them and having a look at that. So one of the big moves forward as well is around what's called the collective impact model. And what that means is when we work in partnership and clear around roles throughout the sector, we provide a much stronger safety net for young people under what we call this tightrope of adolescence that can be so overwhelming and distressing at particular times. And the more we build this safety net through the collective impact, the more likely we will see young people move across that precarious tightrope to the solid ground, which is moving on with life, not having to be burdened by mental health related condition. So early identification, notice some of the early signs, watch over a period of time of which they're occurring, not to dismiss it as merely adolescent behaviour or as a fad. And also as well for GPs is consulting with others and having a nice, small, concise, perhaps kind of solid understanding of the nature of the condition that they're confident of reflecting back to parents or the young person. Change is possible, and like I said, I think it's through partnership is our best way forward.
And thanks to Chris Harris for his time. Now let's go back to our main discussion with Dr. Christopher Lee, Dr. Margaret Lumley and Dr. Olga Ward.
I know that a lot of the patients with personality disorders have coexisting mood disorders. Is your treatment approach a little bit different if you've got somebody who's, as you say, whose thinking is a bit more rigid than if you're just dealing with somebody who's, say, lost their child in a car accident and is roaring out a good-going depression?
It's quite a difficult area, really, because with some of the personality disorders, depression is built in. For example, with the narcissistic personality disorder, they're always unhappy and sometimes syndromally depressed because life never goes the way they want it to. Other people are never good enough, the circumstances are never good enough, they've never got enough stuff, etc. and so forth. And so they're always miserable. And so the only thing that's going to help that depression is psychotherapy. But they present as so depressed that they usually cycle through all the antidepressants and sometimes ECT without any help. And that can become quite a little bit self-defeating in itself, because each time a new therapy is brought in, there's some hope that it'll magically fix things, but it's not going to, because it's actually a part of it's a personality reactive thing. It's not about a major depression, even though it can look quite like major depression. But having said that, they also are vulnerable to have ordinary major depressions, in which case you have to get on drugs.
It's quite useful to have them, I guess, on a background antidepressant while
most
the therapy is going on?
Yes, most of them are. So most patients who look like they may or may not be depressed are on antidepressants. Well, I shouldn't say may or may not be depressed, but anxious people and people who are having difficulty getting going and things like that. Sometimes non-specific things can be helped by antidepressants, sometimes not. But most people would keep them on antidepressants because not to do so just seems remiss. They may not need them.
There's that study that looked at people with antisocial personality disorder, where being depressed and having antisocial personality disorder meant you did better at therapy. So sometimes it helps if there's a little bit more kind of like pain there, for particularly the more externalising ones.
Is that because that makes them engage?
That makes them more vulnerable, so that it's easier. A lot of the therapies are about getting to the underlying vulnerabilities. So if they are already depressed, there's a sense with someone with antisocial personality disorder that there isn't something working about my life.
And just relating to the therapy, quite often the patients, I guess, they're quite resistant to the idea of having a disorder, apart from maybe your borderlines who just welcomed having a label. But if they're quite resistant to having a label, or terribly offended by somebody saying you've got a narcissistic personality disorder, how do you form a therapeutic alliance with somebody who's either in that kind of narcissistic state, or in fact the patient that the cops call you into, who's an antisocial, who's in jail but who's threatening to do something noxious if they let him out?
Yes, well, one of the things you have to do is, in order to communicate with someone, you have to communicate on their level. And so it's not particularly useful to do something different to that. So some people are going to want to know things about what their diagnosis is, and some people aren't. And there's always ways to couch things so that it sounds reasonable, it sounds acceptable to that person. That may be seen as maladaptive on my behalf and manipulative, but it's about what works to form a connection with this person. So
say if you were trying to connect with somebody who's terribly narcissistic, what approach would you use?
Well, I usually tend to tell narcissistic people that they're quite delicate people, and that they have particular needs and particular, they have particular standards and particular needs that they really want to maintain. They get very distressed when other people don't come up to these standards. They're easily hurt and easily angered. And just put it in those kind of terms. And if I was going to explain narcissistic personality disorder to them, I would say that, because that in fact is the truth. There's also a pejorative way in which people use the term narcissist, and we know all about that. But in fact, narcissistic people are very fragile people that are easily damaged and easily lose the cohesion of their sense of self. And this is something that they don't mind being told. And you say, well, you know, I can work with you to help you to feel better about this, and, you know, to sort of learn different ways to do things so that you don't have to feel so endangered much of the time.
Yeah, and Chris,
That sounded beautiful.
It did.
Yeah, yeah. I'd like to trot that out for my next narcissistic patient.
It's a well-oiled.
What about you, say the sociopaths that you said you can establish a connection when they're very depressed? How do you find a way in there?
When they are depressed, it's very easy to look at the underlying vulnerability, and so it's very easy often to go back to the childhood experiences where they perhaps felt most alienated from other people, and accessing those memories and the pain that goes with that sets up a situation where I feel like help reprocess those experiences. Without that, they're more going to be kind of like focused on the therapy, kind of like things that you might do that they feel are thwarting them in their whatever it is that they need to go to. So that's what I think the key thing is different.
One of the other things that general practitioners do see is almost the charming con man. Certainly the charming, slightly sociopath who's really just after drugs. Suggestions for walking on eggshells around these patients?
It's really hard.
It's
really hard, and people who get sucked in by these people are just being normal.
Yep.
So it's tricky for GPs. It's tricky for anyone really, because unless you know these people, you can't call them. You know, you sometimes are left with a bit of a gut feeling that I was probably just done.
Yeah.
But at the time, they overwhelm you with their, you know, effusive goodness and how wonderful they are and how needy they are and how much you're going to help them. And we all, you know, like to have our help part appealed to.
Yeah.
And so you just feel, we can't help being seduced by some of these people. What's helpful, of course, is to get information from other professionals or other family members or anyone really. But GPs don't have time to do that.
No,
in psychiatry, we have the you know, we're good fortune to be able to get collateral histories, but it's gut with GPs, and GPs are often on their own and frightened. They're afraid to say no to these people because they know that will lead to a rage outburst. They're often working on their own. They're, you know, unprotected in a sense.
It's just you and the receptionist.
Yeah, that's right.
And the jolly patients between you and the door.
That's right. Yep. And so the best thing to do under those circumstances is to give the person something that they seem to be needing, and if that's a small amount of medication or something like that, that's okay. And probably try not to see the person again, but that's easier said than done as well, and it's obviously not possible in remote rural areas.
Chris, other suggestions?
No, not so much suggestions, but I think we're learning more about, within the antisocial group, the more that have the psychopathic tendencies. So quite excited about some of the recent research that's come out about that, and hopefully that's going to inform clinical practice better. But like, I'm reminded of a recent Dutch study where they got people with antisocial personality disorder and borderline personality disorder. They did some things to help them get angry, and then looked at their ability to problem solve and what was happening physiologically after they were angry. And the yes, I know, making people with antisocial personality disorder angry is an interesting experiment. And so
lock away the weapons first.
That's right. At the end of the time, it was very interesting. The people with antisocial personality disorder who scored low on the psychopathy checklist, they were saying they were very angry, and their blood pressure went up and their heart rate went up, and their ability to problem solve went pear-shaped. It became really terrible at changing the track that they're on. The subgroup that scored high on the psychopathic traits, once they were angry, their blood pressure dropped, their heart rate dropped, and their ability to problem
the cold
solve,
professional.
actually
disturbing.
got better from that. So really chilling.
They're the ones who need to be sourced as government assassins or something.
I think within prison system they need to be treated differently than the ones who don't have that characteristic.
Given that we've talked a little bit about self-protection and knowing, and I guess getting back to the borderlines who are unfortunately the ones who we can, I guess, most easily identify, how do you stop yourself from kind of getting almost sucked into their chaos?
The first one is everyone who works with this patient group needs to understand they will be triggered. It's kind of like impossible not to be. And so the first thing is not to give yourself a hard time for having done that.
So if they go off and get very angry with you and chuck things in your office, okay, that was just part of it, yeah?
Also, if you suddenly have murderous rage towards them,
Yeah.
because they invoke feelings in us that you just don't get in other circumstances.
And that can vary from kind of like feeling helpless or incompetent or very angry. A whole range of emotions are possible. So I think that's the first thing. Once you kind of like accept this is what happens when you treat this patient group, I think that's the single most important thing to kind of do. From that acceptance point of view, and this is also what we teach the patients to do about their own emotions, it becomes much easier to problem solve how you're going to handle that the next time they're in the office.
And how do you handle that?
How do I handle it? Well, personally, like I have a range of things. Sometimes if they're being part of our research study, I look at their scores on the questionnaire and go, wow, you know, this person is out there in terms of their anger and hostility, so no wonder I'm feeling that way. That sort of is really helpful.
Okay, I think the only score that we've got on the general practice thing is a K10.
K10 is going to help you very
for
much.
all the usefulness that it has.
And then the second thing from there, what I'm always trying to do is when things are really chaotic, is to find what it is that they're saying that's valid and respond to that. So within the things that they're hearing, pick what's valid, make sure to respond to the valid. So that's a general rule.
The other thing about the intense feelings that they arouse in you, I mean, that's basically their feelings or reflections of their feelings. You've got them in you. But having experienced those intense feelings in oneself, you can also feed it back to the patient. Well, no wonder you do this, this, this and this, because I think I just picked up on a little bit of your, rage or despair or hopelessness or something. And, I understand how terrible you feel. And that's very powerful for them to
So you're validating their feelings and then and your feelings, I guess, and then you can move on and say, okay, what can we tackle within this? Yes.
So what can we do to reduce this sense of helplessness? What can you do next time, etc. and so forth?
Patients who are having a lot of swings, who are borderline, and they do seem to go up and down. How do you differentiate that from somebody who's bipolar?
That's very difficult, and
I'm glad you said that. Because
well, and the other thing is,
it does seem quite confusing.
Everyone wants to be bipolar these days, and they go, "It's my bipolar," and I'm like, "No, it's actually your borderline personality disorder." But
well, they'd probably rather be Robin Williams, Well,
they all read about, bipolar disorder, and they read about the drugs that are used to treat bipolar disorder, and they all want them. It's a problem for clinicians. I worked with a registrar for a year or so who was fascinated by bipolar and called everyone bipolar, and I disagreed strongly with him. And a paper that was delivered at a psychotherapy conference I went to looked at this particular thing, and what they said, which I thought was quite helpful, was that in borderline personality disorder and bipolar disorder, there are different sorts of affect. So borderlines have rage, they have this intense loneliness, they have, excruciating uncertainty about things. They have intense feelings, but they have different intense feelings to the bipolar people who have profound depressions. Even if they're rapidly cycling, they have profound hopeless, helpless depressions. They have highs, they have manic episodes where they feel wonderful, or they feel very irritable. Irritability is also, a manic equivalent. But this is different to the qualities of feelings that you find in borderlines. It's still hard.
What would happen if you mistakenly gave a borderline some lithium?
Oh, they get given lithium on a regular basis.
Yeah.
Sometimes nothing happens. Sometimes they have some improvement, and it's hard to know exactly what this is about. The problem with lithium, of course, in borderlines is that lithium's not very good if you take overdoses of it.
No.
And borderlines tend to overdose on anything that's around if they get the mindset. So it's a problem with lithium and other very toxic substances.
Thanks for clearing that up at least a little bit.
So there is some hope, but it's still complex, and difficult. And a lot of them do get put on mood regulators, like sodium valproate and things like that, to see if that will take the edge off the swings. And for some of them it seems to. And I don't really know what that's about.
No, I pass on that one.
Margaret and Chris, any final comments or words of wisdom for GPs who are struggling along with personality disordered patients in remote or rural practice?
I think the important thing is that it's never hopeless, and people with personality disorders do get better, sometimes just spontaneously. But there's lots of different things and you know, emerging treatment options that can be used. For example, there was one psychologist who was recently telling patients before they came to see him to get hold of a copy of Mindfulness for Dummies, and learning mindfulness. And there's lots of different books out for mindfulness now, and patients go and buy these things and find them really helpful. And that's all about regulating what you're doing, what you're thinking, and regulating how you're feeling by focusing on the here and now. So these new potent ways of dealing with things are emerging all the time, and they do allow patients to actually just fully assume responsibility for what's going on and start to make things different for themselves. And if they can be nudged in those directions, that can be incredibly powerful.
That's worth knowing.
I would also echo the idea that I think things are developing. I think we're getting better at treating personality disorders. And I also have some optimism that the internet's going to provide more useful means of delivering services. So there's a trial in Germany at the moment on a self-help program for borderlines. It's meant to be used in conjunction with some therapy, but it might actually decrease the amount of time that people need in the one-to-one.
It's a bit like those mood gym type things that
It's also the
up.
stuff on Beyond Blue, because they've got a bit of a,
Yeah.
you know, if you follow these steps, you'll feel a lot better. And that, you know, if that can be
And the
done,
people who do follow them do get better.
they do.
So
It's absolutely
yeah.
amazing.
Yes.
So if we can have those sort of things for personality disorders, we can do a great deal of good.
Excellent. So I guess we can encourage the patients to at least
To go out
try and
and see.
engage and seek some of those things from a reputable site. And hopefully they speak German.
Yeah, well, there are YouTube things at the moment on kind of some of the approaches like, we haven't talked about yet, but dialectical behaviour therapy is a thing that has some evidence base. There are YouTube sites from people talking about that and teaching some things that can be helpful. There's another approach called schema therapy. There are some things on the web about how you use that to do it. And I think that will just be an area that will increase.
Thanks to Dr. Christopher Lee and Dr. Margaret Lumley. Well, finally for this program, we went to the Drug and Alcohol Youth Service where Clinical Coordinator Alan Coulthart gave his advice on how to start that open, honest conversation about drug and alcohol use with adolescent patients.
So DAYS is an integrated service between government and non-government. So the government part is Next Step, which is part of the Drug and Alcohol Office, and the non-government part is Mission Australia. So we have staff here from both areas. And we have sort of four main components to the service. We have outpatient counselling and appointments. We have a 2-week youth withdrawal and respite service, which is a detox service. And we have a 3-month residential rehab program. And then post that we have some supported accommodation and some independent accommodation as well. We see young people between 12 and 21, and once we start seeing them we can see them up to the age of 23. For the residential services we tend to be quite careful about having young people under 15 or so because they may be in with 20-year-old injecting drug users, so we'll do that sort of case by case for the younger ones, and generally we'd like them to do some sort of counselling or other work before coming into a residential service because of the concern about that sort of contagion effect looking up to these older kids who are, you know, using lots of drugs. A lot of them have been through detention services and that sort of thing. So that's the age criteria. The other criteria is that their drug and alcohol use has to be having a significant impact on their life, and that they want to come in as well. So we don't, we don't see people who are being forced by someone to come in. We do our best to work without a wait list in terms of referrals and being seen and following them up. So as soon as someone's referred, we allocate them to a case manager. We regularly have rural referrals, so both in our detox program and in our residential rehab program. We have young people come. I think at the moment we have someone from Carnarvon. We've had people from all the regions across Western Australia. So people can be referred in. If they're coming from a rural area, usually we'll need to do some assessment with them over the phone and hopefully work with an agency that's working with them. So we encourage them to be involved with their local community drug service teams so that I guess we're not seeing a detox or rehab as the magic fix, that's just part of a program, and they'll need some work prior, looking at their goals and plans before they come in, and then work afterwards as well. If they just come in, go back to the same environment and same things, then generally things aren't going to change for them. So they can be referred into our residential services. We'll work, as I said, with those agencies. We'll do phone contact usually with the person before they come in. The person will usually need to have a supportive adult in the city, so usually a family member. The reason for that is that we don't lock the doors or anything, people can leave. So if we have like a 15-year-old coming down from the Kimberley or up from Albany who's never been to Perth before, if they have an argument and leave in the middle of the night, we can't restrict them, but we need someone to call that can look after them and that sort of thing. So we have had family friends do that before, or for someone it was a chaplain, someone involved in the church, but usually it's family members. We have had families come down and stay in Perth at the time that their child is doing detox before, so that has worked as well. So there needs to be some sort of a plan for what would happen if they would leave, particularly I guess the younger they are, the more the requirement for that. Obviously in some of the more remote places there's less access to local teams as well, so we're aware of that as well. So yeah, I guess both. You can certainly refer into us. I guess we encourage you to talk to the young person about their drug use. Talking about confidentiality is really important in working with young people, particularly in small towns where they know other people, and also about their concerns around their parents and what they're going to find out about what's being told. So addressing confidentiality, addressing the issue, so asking them directly about their drug and alcohol use. And we're aware that young people sometimes over-report or under-report their use, so we'll take that into account too and ask for your opinions on that. It's going to be the norm that young people using drugs and alcohol, at least experimentally, so I think having that conversation with them about what their drug use is and what their alcohol use is, so that you get a good understanding of that, and so that it's out in the open and they feel that you're comfortable talking about it with them, is really important. And then it's about talking to them about what sort of issues or impacts it's having on their life. So is it affecting schooling? Are they missing school because they're wagging to smoke weed, or because they're too hungover to get up and go to school or whatever? Are they doing things to get money to buy drugs? Is it impacting their relationships? Are they having fights with their family, with their partners, with their friends about how much they're using? So I guess it's really trying to build a relationship with the young person. The better the relationship you have with them, the more comfortable they're going to feel talking to you. I guess young people often won't feel comfortable talking to an adult authority figure about sensitive issues like drug use. So I think really building that relationship, being open to asking questions, and for them to feel like you are comfortable talking about this, and what they tell you is confidential as well. So as I said before, being really clear about that confidentiality. In drug and alcohol talk, we talk about the stages of change. So being aware where the young person's at. So are they sort of, in our speak, pre-contemplative? They're not even seeing their drug use as a problem at all. In that case, it might be more about harm minimisation sort of thing. So talking to them about if they are going to use, how they can do that more safely. So being careful if they're sniffing things, to not be doing that around the road, making sure that they're around people that they trust and that they're safe with. Whatever they're using, if they're injecting things, to make sure that they're doing that as safely as possible. So I guess that harm min. If they're starting to think about if there are some problems with their use, then we sort of look at motivational interviewing. So looking at the good and the less good things about their use. How would they know if it became a problem that they needed to do something about? How does their use fit with the person that they want to be, with their values and that sort of thing? So for a lot of young people, they might be having to steal to use, or they might be acting in ways that don't really fit with how they want to be. They might be yelling at their partner or at their parents and stuff, and even though they care about those people a lot. So trying to look at helping that to increase their motivation to change by looking at some of those sort of inconsistencies there. If they're at a stage where they're ready for action and planning, then looking at giving them the options. These are the options for residential services, for counselling services and what have you. So I guess targeting the treatment to where they're at around their use. If someone's at that pre-contemplative stage, not ready to make any change, and you're talking about going to a detox or a rehab, then you're just missing it and you're not going to get anywhere. And similarly, if someone's ready to make changes and you're talking about harm min sort of stuff, you're missing that. So you're really, I guess, trying to target it where they're at. So having a good understanding and talk to them about what they're using, but also how that fits for them and their ideas about whether they might want to change. But I think the most important thing is just being able to have the open conversation with them, for them to feel comfortable to talk to you. The thing with working with young people around drug and alcohol issues is most adults will start their drug and alcohol use in their adolescence, so in that time. And if you can make a change in their use at that time, that can often have a huge difference in their adulthood. Once someone has been part of a drug using lifestyle for a long period of time, it's very difficult for them to get out of that. A lot of their life is invested in that, their friends, how they get their drugs and those sort of things. So if you can, rather than someone's use starting here and going right up there, if you can make a change here, it may mean that they go there or they go up a bit and go down. So you can have that huge change in the long term. I think young people tend to be more open to looking at different ideas as well. So adults may be more set in their ways. Young people, that can be frustrating that they're going to change their mind a lot, but it also gives you something to work with. They often have a lot of energy and humour, and using that when you're working with young people can be really useful as well in terms of building that relationship with them. And they're also developing their identity as well. So you can, a lot of them might be, have their mates that they smoke weed with, but they also play in the footy team and stuff, and they're still working out who they are and what's important for them. So again, you can have maybe more impact on their life by having some sort of conversation with them, or talking to them about their drug use at this period of time. So I think it is a really important thing to do for them to feel comfortable. And sometimes just having an okay experience with someone who's listened to them and hasn't tried to tell them what to do. Well, even if they're using drugs and they don't want to change at that stage, maybe a year or two down the track when they've been kicked out of home because of that or whatever, oh, that doctor wasn't too bad, so I'll go back and talk about them. So we get that a lot here. We see young people who are at a stage and then they go away, we wonder what happens to them, and then a year or two later they come back and they're at quite a different stage, really ready to make some changes. So I think having that positive experience of help seeking, whether they make changes or not at that time, can be really important in that sort of long-term outcome for young people. So yeah, we can make big changes and really have a big impact on how they see getting help, talking to a health professional, and those sort of things. If they have that bad experience, it might mean that they just try and deal with things on their own. But if they have a positive experience, and I guess the doctor's the person that they're often is going to be the front line that they see. If they have that good experience, they feel like they've been listened to. I think it's really important. You hear their story first and you really listen to them. And also that they're not judged and stuff. And we all like to think that we don't judge, but a lot of drug using young people try and bring some negative judgment on them. So being really careful about that. But if they feel positive about that experience, I think that's a fantastic thing that you've provided them and can really help in their long term. Yeah.
Thanks to Alan Coulthart from the Drug and Alcohol Youth Service, and indeed to all our guests for being involved in the program. We'll be back on the 4th of March with a program looking at reconstructive surgery. I'll see you then.